Thank you so much, Jason, for the introduction. Good morning, everyone. I'd like to say thank you to the conference organizers for the opportunity to present on behalf of my co-investigators and study staff on rapid hepatitis C treatment access with peer support at opioid treatment programs in North America, a multicenter type 1 hybrid effectiveness implementation randomized controlled trial. Our work is supported by AbbVie, including the provision of study drug to participants. Hepatitis C treatment with oral direct-acting antivirals is effective. It is associated with a reduction in morbidity and mortality and prevents transmission of hepatitis C to others. People who use drugs are disproportionately impacted by hepatitis C treatment, but also have some of the lowest rates of hepatitis C treatment uptake. There are multi-level interrelated barriers to accessing care for people who use drugs, including a disconnect between where people who use drugs access services and where hepatitis C treatment is provided. Opioid treatment programs in North America are government regulated, and they have as their primary aim the provision of outpatient evaluation and treatment for opioid use disorders. Very few OTPs provide hepatitis C testing, even fewer provide hepatitis C treatment. Integration of hepatitis C care into OTPs has the potential to increase uptake of hepatitis C treatment. However, the optimal approach to integration into OTPs is unknown. As such, we conducted the Rapid Hepatitis C study, which is an open-label phase 4 pragmatic trial. It was designed as a hybrid type 1 effectiveness implementation trial with effectiveness assessed through a randomized control design. The intervention was hepatitis C treatment with glecaprevir, pibrentasvir at OTPs provided by OTP staff with peer support versus the standard of care in North America, which is currently off-site referral to a specialist. We worked across 5 OTPs in 4 cities. We evaluated implementation outcomes of acceptability and appropriateness and focused on the implementation and maintenance domains of the RE-AIM framework. This was done through qualitative in-depth interviews. Sites were brought on sequentially, with the first site initiating study enrollment in September 2021, and the last site, Toronto, initiating in April of 2023. Patients were eligible for inclusion if they were adults, were antibody reactive, or had detectable HCV RNA, had not previously been treated with oral direct antiretrovirals, were not pregnant, and if living with HIV, were on stable ART or had a CD4 count over 500. Patients could not participate if they were pregnant, if they had decompensated liver disease, including a platelet count less than 150,000, history of HCC, or if they were unable or unwilling to discontinue or switch medications contraindicated with glecaprevir, pibrentasvir, for example, HMG coenzyme A reductase inhibitors. The intervention groups were on-site treatments with peer support. This included immediate linkage to a trained peer. Our peers were OTP clients with lived experience of hepatitis C who were trained to support other patients at the OTP with HCV treatment initiation and provide adherence support. Participants also had access to on-site hepatitis C treatment at the OTP provided by staff designated by the OTP. All study participants had access to study drug. The off-site specialist referral arm had facilitated linkage to care at an off-site specialist center with a guarantee of an appointment scheduled within 2 weeks of randomization if they called the number that was provided to them. Our intervention, in a little more detail, included a training provided to OTP staff on hepatitis C treatment evaluation and treatment. This was conducted by a specialist and lasted for an hour. To support confidence in ongoing assessment and prescription, we developed a provider hepatitis C treatment determination tool, which was interactive, allowing providers to include key characteristics of patients and laboratories needed for treatment evaluation, and also included reminders of other aspects of care, including evaluation for drug-drug interactions using the Liverpool interaction tool. We also provided the one-page AASLD IDSA simplified treatment algorithm. All OTPs had access to technical assistance from a specialist at an academic center, and each OTP had peers that were trained to support other OTP clients. The peer mentor training was standardized. It included 6 models, which were recorded videos, some were didactics, and some were role plays. Peers were supervised by research staff who conducted weekly task completion, helped the peers troubleshoot issues arising, and reinforced the training they received prior to initiating their role. We also assessed intervention fidelity assessments. Peers functioned using a structure which included check-in, pre-initiation weekly check-ins, support through 8 weeks of treatment, and post-treatment visits. Support provided by peers was targeted at initiation, adherence support, and providing tools for prevention of reinfection. Here is our study design. Most participants were eligible for consent if they were antibody reactive, and this was because most sites had rapid hepatitis C testing available. Once consented, individuals were randomized at that time, but most participants also got their blood draw for HCV RNA, CBC, CMP, and hepatitis B testing at that time. Once randomized, participants continued in their randomization arm. You see highlighted in blue clinical visits, which included visits at day 1 when the patient showed up for treatment initiation, week 4, and week 8. Study visits were intentionally distinct from clinical visits and only occurred at randomization when a baseline questionnaire was completed, end of treatment, post-week 12, post-week 24, and post-week 36. Overall, we had 182 participants randomized, of which 58 were not enrolled, 38 because they did not have HCV RNA detectable, 14 because their player counts were less than 150,000, and 6 because we just could not get a blood draw. Of the 124 enrolled, 2 were excluded due to randomization error, leaving us with 66 in the intervention arm and 56 in the standard of care arm. These are the demographics of enrolled participants. You will see overall that the characteristics of those enrolled in the rapid HCV arm and the standard of care arm were similar. Overall, the study population was predominantly male. It was predominantly white, with 58% having a high school or higher education level. Most of these participants had been aware of their HCV diagnosis for a while, with a median of 10 years of awareness of hepatitis C infection. About a third of our patients had experienced homelessness in the last 6 months, 62% were food insecure, and the majority were receiving methadone as the medication for opioid use disorder treatment. We also see high rates of moderate symptoms of depression at 45% with a PHQ-8 greater than 10, and 41% with a GAD-7 greater than 10, consistent with symptoms of moderate anxiety. When we look at substances detected at urine screens at baseline, we see high rates of substances detected, with the highest rates of being cocaine at 45% and fentanyl detected in 52% of urine toxicologies. Our primary outcome was hepatitis C treatment within 12 weeks of randomization. The first plot shows initiation in the rapid HCV arm, with 89% of patients initiating hepatitis C treatment within 12 weeks, and in the standard of care arm, 21% initiating hepatitis C treatment within 12 weeks. When we look at time to treatment initiation, we see a median of 19 days with an interquartile range of 11 to 34 days to initiation in the rapid hep C arm, and in the standard of care arm, a median of 50 days, interquartile range 32-57, and we see that both these outcomes were significantly different between groups. I will now focus on SVR outcomes. For our study, SVR was defined as an undetectable HCV RNA anytime from 10 weeks after end of treatment to 36 weeks after end of treatment. In the intervention arm, we see an SVR rates across all individuals that were randomized, regardless of if they initiated treatment, at 61%. And in the standard of care arm, we see an SVR rates across everyone randomized, regardless of if they initiated treatment, at 14%, which was clearly a significant difference. If we go and look specifically at people who initiated treatment, SVR rates in those that initiated treatment was 68% in the intervention arm and 67% in the standard of care arm, which, as you can see, is not significantly different. And if we focus on those that completed all steps of the protocol, including a blood draw for evaluation for SVR, we see SVR rates overall of 78% in the intervention arm and 80% in the standard of care arm. These differences are not significantly different. We do have a number of people who did not get evaluated for SVR, 8 of 59 in the intervention arm, 5 due to loss to follow-up, 2 due to poor venous access, and 1 with SVR still pending. And in the standard of care arm, 3 out of 12 did not have SVR evaluated, 2 loss to follow-up, and 1 SVR pending. I'm now going to shift gears and talk a little bit about our implementation outcomes. And so this shows some quotes related to appropriateness of both on-site treatment and peer support. And what you see here is evidence of high appropriateness. An OTP client said, "I was already here because I come here to get my methadone, so I thought it was just convenient. It was perfect timing." Another OTP client said, "Peer support was wonderful. Because she had already been through it, she knew what I was going through." Looking at what looking at what providers and OTP staff thought, an OTP operations director said, "It's absolutely preferable. It just leads to less fragmented care. It doesn't make sense to have patients traveling all over the city for different things when it can all be done in one place." Another OTP counselor said, "It made this process a lot easier for both me as a counselor and the patient. I feel ongoing regular hepatitis C care should be a part of a program." That's just my 2 cents. With regards to acceptability, we had some differences in opinion. An OTP client said it made a big difference. It's not just something, it's definitely like noteworthy. Just like a single text exchange could settle some uneasiness in me. Getting that reassurance coming from a person where it feels genuine and not just some textbook response. However, another OTP client said, "I wasn't a huge fan of the peer outreach. My peer guy was fabulous. I loved him, he was a great guy, but it started to seem very redundant about halfway through because I didn't have any side effects and there just wasn't anything to report." OTP staff perception of acceptability included high acceptability. A quote said, "As much as we try to make it as destigmatizing as possible, there is still like a hierarchical-like setup where it's like the doctor talking to a patient, the nurse talking to a patient, but we aren't folks who have actually had hepatitis C." I think all of our patients, most of our patients said it was helpful to them. Switching gears and looking at feasibility, a component of implementation, a nurse said, "I mean the tools that are part of the Hep C intervention, the treatment determination tool, the Liverpool Hep C drug interaction thing, those tools are amazing, and they actually make it very easy." Another provider said, "We have to think in a business perspective, and there is no real way to implement a peer support program if we're not a government-funded facility. It's going to have to be based on grants. It will be difficult, but hopefully we can get there." Another provider, who is also an operations director, said, "As a provider, it actually adds a lot more complexity, to be honest. I think it definitely makes the job more difficult, a lot more administrative work required, and more expensive. We have to pay a lot more staff to do that." Overall, we found that hepatitis C treatment at OTPs with peer support was associated with higher rates of hepatitis C treatment initiation and sustained virologic response amongst those randomized to intervention arm versus those randomized to standard of care specialist referral. The test and treat approach was considered highly acceptable and appropriate by OTP clients and staff. Peer support may not be needed for HCV treatment support for all people with hepatitis C enrolled at OTPs, and despite high acceptability, appropriateness, and effectiveness to sustain these models in these settings, OTPs will need additional support, both for staffing and administrative aspects of hepatitis C treatment. These are acknowledgements, and thank you all for listening.
Amazing work, Sean. It's so great to see some randomized trials being presented. We have time for one very quick question. I'm just conscious of time. Does anybody have a burning question that they'd like to ask? I saw one hand go up here. Okay, Brian as well. Quick ones, guys. Brian, and then the hand at the back.
So Brian Conway from Vancouver. Obviously, the intervention is effective, to be congratulated. Some might interpret the SVR rate of the 51 that made it to the end in the intervention group, SVR rate of 78%, is a tiny bit disappointing. So what happened to those 11 people? What was the reason for them having essentially a detectable viral load at the SVR 12 time point?
Yeah, so it actually was only 6 people that had a detectable viral load. The others were just lost to follow-up. This, as you know, is a group of patients that can be hard to retain in studies. Many of the patients were entering the study just as they came into treatment for their substance use, and so that does explain some of the loss to follow-up. With regards to the 6 that had detectable viral load at the SVR time point, there's other data suggesting that there are high rates of reinfection in people who use drugs that are treated for hepatitis C, but that really is an indication that we're treating the right people, and further data will help elucidate if this is really treatment failure, which I doubt. I do suspect that some of this might be reinfection.
Fantastic, Sean. And really quick at the back, do you still would like to add? No. No. Okay. Oh, yes or no?
Yes, I'm trying.
Yes. Okay, sorry.
Oh.
Technical.
Hi, can you hear me? Oh, sorry. Hi, my name's Clara. I'm coming from the US. Thank you so much. This is great data. I'm actually curious because we're on a date, we do some work in New Haven, and we've did a qualitative analysis of a survey, quantitative analysis of a survey, and we noticed that a lot of people who had been treated for hepatitis C were reporting the same levels of high-risk behaviors for transmitting hepatitis C and for reinfection, like sharing of needles and other paraphernalia. And it kind of highlighted to us, we think, a question of the fact that maybe we're like completely failing to give appropriate education as a healthcare system. And we were curious if you have in your intervention actually that you're being educated on high-risk behaviors, if there's like any data, if you followed up on any of those high-risk behaviors, if there's a change in those behaviors, because we would love to like be able to actually intervene in the harm reduction side.
Such an important point. We do have data collected on subsequent drug use behaviors, and hopefully I'll have the opportunity to present that in the near future. Thank you so much.
Amazing. Thank you so much.